Welcome to The Explainer. Today, we're diving into one of the biggest, most time-sensitive emergencies in all of medicine, the ST segment elevation myocardial infarction. You know it as a STEMI, and you better believe this is going to be all over your board exams, so let's get right to it.
So picture this. This is the classic scenario they're going to throw at you on the pants. We're going to walk through the entire story of a STEMI, from the second the patient walks in the door to their long-term recovery. And we're going to hit every single high-yield fact and buzzword you need to know.
Okay, first things first. What is actually going on inside the heart during a STEMI? Well, it all comes down to one big problem, a total blockage of a coronary artery. So plaque that's been building up for years suddenly ruptures, a clot forms on top of it, and bam, the door slams shut, blood flow stops. This starves the heart muscle of oxygen. And if you don't fix it and fix it fast, that muscle starts to die. That's the infarction. Now, plaque rupture is the #1 cause, for sure. But for your exam, don't forget the curveballs. Cocaine use and coronary vasospasm can do this too, especially in a younger patient who doesn't fit the typical profile.
Now, you've got to pay close attention to these descriptions. Board questions absolutely love to use these phrases. This isn't like stable angina. This pain goes on for a while, more than 30 minutes. It happens at rest, and here's the kicker. Giving them nitroglycerin does nothing. That is a massive clue that this is the real deal.
And here is a super important point, one that can absolutely trip you up in real life and on the test. Not every heart attack reads the textbook. In fact, a whole third of them are painless. You have to have a high index of suspicion, especially in women, older folks, and patients with diabetes. If they show up with just sudden weakness, or they passed out, or they're in acute heart failure, you have to be thinking MI. So, your patient is in the ER, your gut is screaming STEMI. How do you prove it? Well, it all comes down to two key tests, the EKG and cardiac labs. Think of this as the life cycle of a heart attack on paper. It follows a pretty predictable pattern. Right at the beginning, you might see these super tall, pointy T waves. We call them hyperacute. Then, the main event. The ST segments go way up. That's the hallmark. Over hours or days, you can start to see Q waves develop, which basically means that piece of muscle is gone for good. And finally, T-wave inversion as things start to scar over. You need to know this progression. Okay, everybody listen up. Burn this sentence into your brain. This is one of the highest yield phrases in all of cardiology. If you see a brand new left bundle branch block on an EKG and your patient has chest pain, you don't hesitate. You don't wait for labs. You treat it as a STEMI, and you get the cath lab on the phone. End of story. All right, labs, troponin is our go-to for the initial diagnosis. It's super sensitive, super specific. But here's the testable pearl, the little nugget of info you need to know. Troponin stays high for a week. So it's totally useless if you think your patient had a second heart attack 3 days later. That's where CMDT comes in. It goes up, but it comes back down in about a day. So if you check it again and it's gone back up, bingo. That's your high-yield clue for a reinfarction. Okay. The diagnosis is confirmed. The EKG shows it, the labs are pending. Now it is a flat-out race against the clock. The mantra you need to live by is time is muscle. Our one and only goal is to get that blocked artery open again, right now. So we've got two main weapons. The absolute gold standard is primary PCI. That means rushing the patient to the cardiac cath lab and physically opening that artery with a balloon and a stent. It just works better. But if you're in a place that can't do that quickly, your next best option is fibrinolytic therapy, powerful clot-busting drugs. 90. This is the number. For PCI, the goal is a door-to-balloon time of 90 minutes or less, from the second that patient enters the hospital to the second that balloon inflates in their artery. 90 minutes. And for fibrinolytics, the clock is ticking even faster. The goal for door-to-needle time is 30 minutes or less. Know these two numbers cold. They will come up. All right, so while the cath lab team is scrambling to get ready, what are we doing for the patient right now? You might have learned the old mnemonic, MONA, but honestly, the modern STEMI cocktail is way more specific and evidence-based. Think of it as a four-pronged attack. First, we go after the clot itself with antiplatelets to stop it from getting bigger. Then we add an anticoagulant like heparin. Next, we protect the heart muscle that's still alive by giving a beta blocker to slow it down and reduce its oxygen needs. And finally, we're already thinking about the future, starting an ACE inhibitor for long-term survival. But what's the very first thing you do? Give them a full-dose chewable aspirin. Immediately. Okay, phew. The artery is open, blood is flowing, and your patient is in the cardiac care unit.
But we are not out of the woods, not by a long shot. Now we have to be on the lookout for all the high-yield complications that can happen after the main event. Where the heart attack happens is a huge clue for what kind of rhythm problems you can expect. See, inferior MIs often knock out the blood supply to the AV node, so you see slow heart rates and less dangerous types of heart block. But anterior MIs, they damage the heart's main wiring, leading to the much scarier Mobitz type 2 block, which is a big deal and often needs a pacemaker. This right here is an absolute gift on a board exam. If you see this triad, low blood pressure, lungs that sound totally clear, and bulging neck veins in a patient with an inferior STEMI, you should be screaming right ventricular infarct. And here's why it matters. These patients are preload dependent. Their stunned right ventricle needs a ton of fluid to push blood forward. If you give them nitrates or diuretics, you pull that fluid away. Their pressure will crash, and you could cause a total collapse. Do not give them nitrates. Here's another test writer favorite. It's a few days after the MI, the patient seems to be getting better, and then, bam! They're suddenly in full-blown heart failure. You hear a brand new, loud, harsh murmur at the apex of the heart. This is a papillary muscle rupture. The little muscle holding the mitral valve together has died and torn. This is a true surgical emergency. So remember how those ST segments are supposed to come back down to baseline after a few weeks? Well, what if they don't? If you get an EKG a month later and those ST elevations are still there, just hanging out, that is the classic buzzword sign that a ventricular aneurysm has formed. It's basically a weak, bulging scar on the heart wall. And last, a delayed complication. The absolute key here is the timing. This isn't just some irritation of the heart lining a few days after the MI. No, this happens weeks, even months later. It's an autoimmune reaction where the body's own immune system gets confused and attacks the heart. That time delay is the whole point. And remember, our job isn't done when the patient is discharged. That's really just the beginning of the next phase. These medications are their survival toolkit. Dual antiplatelet therapy for at least a year, lifelong aspirin, and a powerful statin. And they'll stay on their beta blocker and ACE inhibitor pretty much forever. This is what keeps them alive. So, let's put it all together. The fire is out, but part of the house is burned down. Now, the heart muscle is going to try to compensate, but it does it in a bad way. It gets stretched out, weak, and baggy. We call this adverse remodeling. So what's our #1 medication to stop that from happening? And the answer is ACE inhibitors. They are absolutely critical. They block the whole hormonal cascade that leads to that negative remodeling, which is a huge reason why they improve long-term survival so much. And there you have it, our deep dive into STEMI. If you can master this pathway, from presentation to long-term care, you'll be set for your exams and, more importantly, for taking great care of your patients.